Okay, we're continuing with this book here, Prevent and Reverse Kidney Disease by me, Pete Rogers. This is part 17. And the first thing I'm going to talk about is why you don't want to be half-assed with your diet and your low-protein, low-fat, low-sodium diet, because there's a lot of variables in health. And, you look at a standard anatomy textbook or something, and you're always going to see standard anatomy. Imagine my fist is the heart, and then these arteries on the outer surface of the heart. These are called the epicardial coronary arteries. These are the ones everybody's heard of. Left main coronary artery, that's called the widowmaker. CX is for circumflex, left circumflex. LAD is left anterior descending coronary artery. When you get a cardiac cath, cardiac CT, they're going to talk about these arteries. There's also a right coronary artery comes off this way. This is the ascending thoracic aorta. These are the aortic valve cusps. All right. So what I'm getting at is people will sometimes have normal variation. Normal variation is a common thing in the human body. And you can have an extra branch coming off the left main. It's called a ramus intermedius. Well, when you have a ramus intermedius, you have more turbulent flow. You also have smaller branches. Those are both negative prognostic factors. What that means is more turbulent flow. You're going to form more clot, more atherosclerotic plaque. In my other lectures, I went through the mechanism of hypertension is prothrombotic because the excessive amounts of turbulent flow as well as these retrograde, backwards eddy currents, they confuse the epithelium, the endothelial lining, and it'll shed its antithrombotic glycocalyx when there's hypertension present, and you start forming little clots on these arterial walls. When the artery is small in diameter, it's harder to do a surgical bypass, it's harder to place a stent. So they're more difficult to work in small arteries. So what I'm saying is, you could very well have, 20% of people got a ramus intermedius. That increases your risk of having coronary artery atherosclerosis and, having a difficult situation to revascularize with stent or with CABG or a cardiac event. So nobody knows what you got, and there's a bunch of these things in the brain, like bilateral persistent fetal posterior communicating arteries. The relevance being is you could have unfavorable anatomy. You have no way of knowing it unless you've done, a CT angiogram, a cardiac cath, a cerebral arteriogram, MRA, magnetic resonance arteriogram. You don't know. So the wise move is to assume you do and just be extra careful with your health. If you got bilateral persistent fetal PCOMs, then you have increased risk of a cerebellar stroke. That's another normal variant. I see it every day in the brain, so just assume you have it. I don't know the percentage of it, maybe 15% of patients, something like that. Okay, here is another paper about ramus intermedius. Okay, the ramus intermedius independently increases the risk of atherosclerotic plaque formation in the left main stem, coronary artery, and its proximity, the adjacent branches. Ramus intermedius is believed to exert altered hemodynamic effect, promoting atherosclerosis plaque formation, like I was just talking about. Okay, now we're going to talk about hypertension, which is kind of related to all that. Hypertension and hyperlipidemia, high cholesterol, the main risk factors for atherosclerosis. The reason why it's worth talking about hypertension is we're talking about kidney failure, all right? And so what's the most common cause of kidney failure? Diabetes, number one, and then also hypertension and atherosclerosis, okay? Most people on dialysis have both hypertension, diabetes, okay? And there's also autoimmune causes of kidney failure. But if you got an autoimmune cause of kidney failure, you also don't want diabetes and hypertension. How do you avoid hypertension? Eat a low-fat, low-sodium diet. That's the most important thing to know. And like I said, too, don't expect your doctors to know this. I can tell you, a lot of kidney failure patients, nobody says anything to them. They never get a dietitian consult, renal dietitian certainly, and the nephrologist doesn't know anything about it. They had Medicare approval of dialysis in about 1972, and once they did that, people stopped paying so much attention to trying to prevent them from full-blown end-stage kidney failure. They figure, you're going dialysis. But dialysis is not such a great thing. 50% of them are dead in 5 years. It's like having malignant cancer. You want to prevent going on dialysis, all right? And so what I'm saying is before 1972, they were much better about knowing these low-protein diets, very low-protein diets. A typical patient will have kidney failure. No one will ever tell them anything until they crash and burn, they're on dialysis, all right? And then they're kind of screwed. And so here's like the typical textbook. These are how students are educated. It's been this way my entire career. I went to medical school many, many years ago. Gosh, like 40 years ago, all right? And this is what was taught. 95% of hypertension is idiopathic. Doctor's an idiot, patient's pathetic, of unknown cause, called essential hypertension. And, you know, when you first read that, you think, oh, gee, you know, that's just the way it is. Like the typical chapter on chronic disease in the modern textbooks will be, it's associated with aging, seems to be part genetic. Sometimes it might be related to sequela from an infection. You know, we don't really know. It's all BS. Or sometimes it's socioeconomic disparity. They're all trying to throw racism in there, some other bullshit, okay? I can tell you, it never is. The poorest people in the world, they don't have these diseases. It's just what you eat and whether or not you're exposed to a couple toxins, all right? We know that because the incidence of hypertension, diabetes, coronary heart disease, obesity, it's like 0 in a starch-based plant-eating population. Okay, and the reason what they're telling you is when you don't know it, the way you cure disease is removing the cause. If you don't know the cause, then you don't know the cure. And you just put them on drugs for their life, okay? And that's why I can say with such 100% confidence that conventional medicine is a joke for the chronic diseases. Okay, that's what I was kind of talking about. They just match the ill to the pill, send the bills. And this is like as stupid as a doctor from the 1700s, you know. You actually could get better results doing a phlebotomy. You'll lower the hematocrit, which will lower the blood viscosity, and that'll decrease their hypertension. Okay, that could be beneficial. And the other reason I'm so confident, we know, you know, from Kempner's results, Pritikin results, McDougall's reports, all the epidemiology and the other people who tried this and all the animal studies, low fat, low sodium diets, they prevent hypertension, diabetes, coronary heart disease, you know. What more do you want? Here's a classic paper, Blood Pressure in the African Native, written by C.P. Donison, Lancet Journal, 1929. You can hit the screen button, the print screen button on and save this paper. It's not always easy to find on the internet. Here, let me put it in the middle of the field here. Okay, so here it is. 1,800 consecutive adult admissions. Okay, adult men in Kenya in 1929. Here it is. No case of raised blood pressure was encountered. Not a single patient. 0 had hypertension. Where they ate a plant-based diet back in those days. No hypertension. Because all the stuff you learn in Western schools is, well, you know, blacks are kind of difficult. They've got, you know, salt sensitivity. It's genetic. You know, they just get a lot of hypertension. There's nothing you could do. Give them an extra medication. That's the best you can do. BS. If the blacks eat a plant-based diet, they don't get any hypertension. 0. 0. They also measured the average blood pressure of a man 60 years of age. So, you know, between, let's say, 40 and 70. Average age was about 60. The African man in 1929 in Kenya had an average blood pressure at 60 years of age of 105/67. Same as like a teenager. Whereas the average European man of 60 years of age had a blood pressure 140/90, hypertensive. So, again, it's not genetic. It's just a question of what you eat. Okay. Sodium is a vasoconstrictor, so it clamps the arteries down, narrows their diameter. So when you're pumping blood through a narrow system, like when you hold your finger over the hose, it's going to go faster. It's going to increase the pressure. If you're, you know, the reason you have blood pressure, pump blood to the top of your brain, cerebral cortex. So if you're pumping thick blood due to the fat sticking the red cells together, rouleau formation, pressure is going to go up. Lack of dietary fiber, you're going to get bacterial endotoxins causing fibrinolytic clots. We talked about that before. Amyloid clotting. That's going to cause rouleau formation, increased blood viscosity. Pressure goes up. Okay. Plants got all the good stuff. They got the dietary fiber and they're low fat. Okay. Let's see. Talked about the rest of this stuff here. Richard Moore also said hypertension is just a symptom of eating a low potassium diet. All right, I think I'll end it there for today. We'll go through that other potassium stuff next time. I hope you found that helpful.